Welcome to our Living Well Breast Cancer Care WA webinar. Today I'm speaking with Christiane Purcell-Wells about lymphedema after breast cancer treatment. But before we open up to our conversation today, I would like to acknowledge the traditional custodians of the lands that we are streaming from today. I'm here on Whadjuk Noongar Boodja, sacred and beautiful country. And I invite you also to reflect on the lands that you are on, to connect with the natural environment, and to remember and offer in your own way respect to the elders of the past, the present, and the emerging next generations. We're grateful to be here, and we're grateful to have the expertise of Christiane Purcell-Wells. Christiane's career path demonstrates her commitment to lifelong learning. She came to physiotherapy from a background in yoga therapy, which was inspired by her personal experience of living with chronic back pain in her younger years. This experience has given her a deep belief in the power of simple lifestyle changes, including exercise, which she'll talk more about, to make a huge benefit to long-term outcomes for health and well-being. Christiane is originally from the UK. I'm sure you'll notice her accent. And she's had a rich and rewarding career across different professions and continents. She's taught English in Mexico. She's worked at Sydney University. And then she finally settled on studying the graduate entry Masters of Physiotherapy at Curtin University. She's worked as a physiotherapist in private practice and in aged care, which has led her to a special interest in lymphedema management, which is what she does as the breast physiotherapist at Sir Charles Gairdner Hospital. You will get to understand and know Christiane's very holistic, person-centred approach. She is a genuinely heart-centred, empathetic, compassionate person, and she knows that integrating self-care into daily life can be challenging. She's committed particularly to empowering women with the tools and knowledge to live their best life after breast cancer. And on a personal note, she's a proud mother to a daughter, a foster parent to various cats from Cat Haven, and someone who continues to practice yoga and meditation daily. So I'm going to hand you over to Christiane now. Over to you.
Oh, thank you, Chandrika. That was such a beautiful welcome, and thank you for that inspiring acknowledgement of country. So yeah, my name is Christiane Purcell-Wells, and I'm going to be presenting today about lymphedema with a particular focus on breast cancer surgeries. And I'll just start by acknowledging my gratitude for the physiotherapy department at Charles Gairdner and also the breast centre where I work. I feel just so lucky to be part of such a supportive team who really get behind helping us to deliver the best quality care and supporting the breast physiotherapy service. I thought I'd share an anecdote from a conversation I had recently with our wonderful clinical nurse manager here in the breast centre, and she said that sometimes people ask her, why do we have a breast physio? And she invites those people to go and look around our waiting room here at the breast centre and ask them, do you see anyone wearing a compression sleeve? And I just thought that anecdote was so powerful for painting a picture of the importance of allied health being involved in the breast cancer journey. And yeah, hopefully that will become clearer through my presentation. So let's dive in. I'm going to talk a little bit about the lymphatic system, so a little bit of basic anatomy and physiology. I'll talk a bit about lymphedema, risk factors, and what we can do to prevent, give ourselves the best chance of preventing lymphedema, and the importance of surveillance and early diagnosis, including the role of allied health. So the lymphatic system. What I've realised from my work here in the breast centre is that the first education people might be getting about the lymphatic system is when they've just received a diagnosis of breast cancer. So probably not the best time to be really learning about anything. But these people are bombarded with information from day one, from nurses, from doctors, from medical oncologists, from radiation oncologists. And then I come along and start going on about the lymphatic system and talking about lymphedema, and I realise how overwhelming that can be. So I'm just so grateful for this opportunity to be able to give this webinar. And our idea in providing this information is that people could access it at a slower level. There could be a resource available for when you're in the, kind of the right headspace to really look into that information, rather than being bombarded with it all at once. So when I first started studying lymphedema as well, I think that I found it so overwhelming myself, and I'd already studied physiotherapy. And so over the years that I've been looking at the lymphatic system, I've just broken it down into this really simple way of understanding it. So I hope that can come across in my talk today. So the word lymph, I'll start with a fab fact about lymph, which I love. It comes from the name for the Roman goddess of fresh water, which was Lympha. So this relates to the clear nature of the lymphatic fluid. And I just think that that's a lovely way of naming it, because our lymph fluid is so important for life. Health in the lymphatic system is absolutely sustains us, and it's a really important system in the body. So some of the main roles of the lymphatic system is it helps to maintain fluid volume in the body. So if we didn't have a lymphatic system, we'd all be puffed out like balloons all the time. Also has a really important role in immune surveillance and response. And it's also important for absorbing kind of larger particles in our body. So this is like digestive fats and also cellular waste and proteins. It's all over our body, as you can see in the slide here. And yeah, we've all got one. So the lymphatic system is an accessory to the circulatory system. So in the circulatory system, we have the heart that's pumping out arterial blood, which nourishes our cells, and then the venous system takes away the deoxygenated blood, and it goes back to the heart, and this goes round and round. So this is a high pressure system. There's large vessels. The arterial, the arteries are large and can handle those high volumes and high pressure fluids coming out from the heart. And that system pumps around about 7,000 litres of fluid each day. The lymph system, on the other hand, is a low pressure system. And rather than circulating, it goes one way. So it goes out from the periphery, and the lymph fluid has to travel all the way back to the heart. It's a low pressure system. It doesn't have the benefit of the heart pumping the fluid around. And it moves around 2 to 4 litres of fluid a day. So the arterial blood flow pumps out from the heart, and some of that fluid will end up out in the tissues as lymphatic fluid. So this is called the lymphobligatory load, and so this is the kind of technical term for it. So a portion of that fluid that's coming out in the general circulation has to be absorbed by the lymphatic system. So we can imagine that the arterial blood flow is like a tap. It's turned on and it's pumping fluid out, which ends up in the tissues. And the lymphatic system's kind of like a drain or an overflow. So when the fluid starts to collect in the tissues, the lymphatic system's going to have to take some of that fluid away. So this happens through a series of lymphatic vessels, which I'll explain now. So as the pressure builds, as the fluid builds up in the tissues, it increases the pressure in that space. So we call that the extracellular space. So the space that's around the cells in the tissues. So the cells take the nourishment that they need from the fluid, and then they will produce some metabolic waste products that come out into that space as well, so proteins, various things. As the pressure builds, it starts to pull open the first vessels of the lymphatic system, which are called pre-collecting vessels. So they have little overlapping cells in those vessels, and as the tissue fills, it starts to pull open those little gaps in the pre-collector vessels, and the fluid just flows in. So if you imagine that little overflow drain that you have in the bath or the sink, it just, when the bath gets too full, it starts to drain that fluid away. Those vessels open and they passively take in the fluid. So this is moving from the area of high pressure in the tissues into the low pressure in that first vessel. As that pre-collector fills up, the pressure increases in that part, and that pushes open a little valve, and the fluid moves into the next part of the vessel, which is called the collector vessel. So this is how fluid moves into the lymphatic system, and then it'll gradually move along through the collector vessels, which have these valves, and they prevent the fluid flowing back into the tissues. From here, it'll gradually make its way into some larger vessels in the torso called trunks, and these eventually become vessels called ducts, which ultimately drain into the venous system up here near the collarbones. And this drains back into the subclavian veins, which is taken back into the general bloodstream to be recirculated again in that cycle. So the best analogy I could think of for this, you'll get used to me, I'll have a little analogy to help explain things, is it's like when let's say we have a downpour of rain, and that might trickle into a creek, which turns into a stream, which turns into a river, and eventually the river flows back towards the ocean. And that's a little bit like our lymph vessels, that they become from really small vessels into larger and larger vessels, and then eventually come back into the general circulation. The difference with this is that, and one of the problems with lymphatic fluid and fluid in general, is that it tends to flow down with gravity. The water will tend to go downhill, but the lymphatic fluid has to, for a lot of its journey, move uphill. So it has to come all the way out from the outside of the body back in towards the heart and up towards the neck. So, and this is, remember, a really low pressure system. It doesn't have much going for it in terms of its own way of moving that fluid. So how does the fluid move back all that way? So in the vessels, the lymphatic vessels, they have a little bit of a muscular contraction. They can help to move that fluid along, but it's not very powerful. It's quite a kind of laid back kind of contraction. And then also the lymphatic vessels tend to be along the pathway, follow the same pathways as the other vessels, including the arteries. So as the high pressure pumping arteries do their thing, they're going to help the lymph vessels to get a little bit of movement with their own pulsation. So those are things that are happening naturally within the body, but the things that we can control are the muscle pump. So the lymphatic fluid is absolutely reliant on our own muscle contraction to move the fluid back towards where it needs to go. And this is why, if anyone's been in hospital for a period of time, you'll be given those Flotrons that are giving the pumping to the calves, or put into some TED stockings, which is going to help to move that fluid along. So for anyone who's immobilized, it's going to be having problems moving the lymphatic fluid. But for able-bodied people, definitely movement and exercise is such an important part of keeping that movement of fluid along the system. The other thing that makes a big difference to the movement of the lymphatic fluid is pressure changes in the thorax. And this is to do with the breathing, and as the diaphragm moves with the breath, as the breath moves in and out, that changes the pressure in the thorax, and it helps to pull fluid back into those central trunks and back up into the system. So movement and breathing, anyone who's familiar with their yoga practice, this is going to be ticking their boxes, because definitely those things together are great lymph movers. The other structure that I wanted to talk about is the lymph node. And so this is the other really key feature of the lymphatic system. So the lymph nodes are these little bean-shaped structures which are extensive throughout the lymphatic system, and then they cluster in certain areas, for example, around the neck, in the armpits, abdomen and the groin, behind the knees. And we probably have around 700 to 800 of these in a healthy lymphatic system. So as the lymph fluid moves along, it has to pass through the node on its journey. And the node acts as a kind of a mini filtration system. So the lymph fluid has to circulate around all these little channels within the lymph node. And this helps to filter that fluid and starts the process of removing some of those cellular waste products. Also, it houses immune cells in the lymph nodes, and so if a pathogen is detected on the lymph fluid's movement through the lymph node, it will stimulate an immune response. It'll trigger the body to release more immune cells to the problem area. So that could even be like having a kind of a localized infection, or indeed having something like tonsillitis or this kind of thing, where we might even see swelling in the lymph nodes, and that's because they're working really hard to help to fight that infection. So the lymph nodes, often with a cancer diagnosis, we'll start to talk about lymph nodes. And that's because when we have cancer in the part of the body, some cells may break off from the primary tumour, and they're going to move along the lymphatic pathway into the lymph node, potentially, if the cancer is spreading. And so a lot of cancer surgeries will include at least what we call a sentinel node biopsy. So if you have a sentinel node biopsy, what will happen is that a small amount of tracer is injected into the area affected by the tumour, and then this can produce a map of the lymphatic pathway to the node that the tumour is draining to, and that's called the sentinel node, or it might be the sentinel nodes, so there can be more than one. And then these will be specifically identified for the surgery. So the surgeries, the modern cancer surgeries, are much more sensitive to the risks of removing multiple lymph nodes, and so it's a very precise process whereby we try to affect the lymphatic system as little as possible. So often with the breast cancer surgery, there'll be a small scar on the breast and also a small scar in the armpit or axilla. If we know that the cancer has moved into the lymph nodes, there might have to be more extensive surgery to the lymph nodes. So that's often called an axillary lymph node dissection or axillary lymph node clearance. And in this surgery, more lymph nodes will be removed from a part of the affected area. And this is obviously more invasive surgery and has a higher risk for having problems with lymphedema. I'll talk a bit more about that further along. So the other thing I wanted to talk about was the difference between edema and lymphedema. So edema basically is just another word for swelling. And how is that different from lymphedema, which is like a chronic disease process? So I mentioned before that we have this lymphoobligatory load. So that is the amount of fluid that ends up in our tissues at any one time that has to move back into the general circulation by the lymphatic system. But that normal lymphoobligatory load, so for example, I'm sitting here talking to you, is only using about 10% of the full capacity of the lymphatic system. So what we call the full potential of the lymphatic system is the transport capacity. And this is like a safety mechanism built in, because at times our fluid will fluctuate in the body. So if we jumped in and did, a pump class and went for a run, circulation speeds up, because the heart's beating more rapidly. And this ends up with more fluid being out in the tissues that has to be taken up, by the venous system or the lymphatic system. So that's going to use more of the transport capacity. If we have an acute infection, or we get a sprained ankle, or anything that causes localized swelling, we already have this capacity with the lymphatic system to deal with a good amount more fluid than it will be usually at rest. But there are limits. So if we reach that full capacity of the lymphatic system, then we get something called fluid overload. So edema or swelling happens when our lymphatic system's normal. There's not any identified problem with the lymphatic system. The problem is that we've just got too much fluid coming into the tissues. So this would be like the tap's on, and that little overflow thing in the sink or the bath, the tap's flowing too quickly, and some of the fluid's going into that drain, but it can't go in quickly enough to cope with how much fluid's coming in through the tap. So these might be from trauma or wounds where we're getting that localized, swelling, infections. If there's a problem with the heart, so the heart can't actually beat strongly enough to keep moving the fluid around the body efficiently. And then if there's any issues with the blood vessels that are taking the fluid away back to the heart, different organ problems. If there's obesity, so when there's more fat cells in the tissue, it makes less room for fluid to move around, certain medications, and also immobility. So if people are not able to move around and walk, and I think often we'll see, maybe with elderly people who are sitting for long periods of time, or indeed people who are, in wheelchairs or this kind of thing. It can be multifactorial, but definitely a very common problem. So this brings me to lymphedema. And the Australasian Lymphology Association gives the definition of lymphedema as a condition where the accumulation of excessive amounts of protein-rich fluid in the tissues results in swelling of one or more regions of the body. So this protein-rich fluid, so this is the waste products that's coming out of the cells and would usually be whisked away by the lymphatic system, but in the case of lymphedema, it's not able to move out through that pathway, and we get this swelling developing. So lymphedema can be primary, meaning that it's more from a congenital defect in the lymphatic system, or secondary. So secondary lymphedema is related to the removal of lymph nodes. Other, cancer therapies such as radiotherapy, some kinds of chemotherapy can be provocative, and different cancer processes can affect the lymphatic system. Trauma and extensive scar tissue, chronic inflammation, and chronic infections can break down the lymphatic system over time. Other disease processes, for example, tropical filariasis, which is a mosquito-borne disease, that once it's kind of in the body, it destroys the lymphatic system. And also burns can be really problematic for those delicate lymphatic vessels. So in the case of lymphedema, our lymphoobligatory node is normal. It's just a normal amount of fluid out in the system. But in this case, we have a reduced ability to drain that fluid. So my analogy for this is, imagine you have a highway and one or more of the lanes is closed. So there's still the same amount of traffic that's coming through. I live in Fremantle, so I know all about this. But it's just that there's not as much potential for that traffic to move along smoothly because the highway is closed for some reason. So yeah, that's I'll talk a bit more about that. So it's not it's not that there isn't other pathways for the lymph to move in, but that's basically how we develop secondary lymphedema. It's because the lymphatic pathway has been disrupted. So traditionally, we would look at 4 stages of lymphedema, and this would be a kind of a common way for people to figure out that they have lymphedema. So they've had some kind of, maybe had a surgery, something like that, and then down the track, it could be 6 months, 12 months, 18 months, even 2 years, there's visible swelling starts to develop in the affected limb. So we're looking at arms here because that's most common after breast cancer surgery. So this is a change in the arm that's visible, but it's very dynamic and it goes away. So if we're using the arm more, if we're doing some stretching or indeed elevation, if we're able to get some gravity assistance. So often people with lymphedema, they feel better when they wake up in the morning. They find that the swelling goes down overnight, and that's because gravity has been eliminated somewhat in the supine position. At stage 2, there's the visible swelling and it loses its dynamic quality. So you're probably going to get more of a kind of constant appearance of swelling in the limb. At stage 3 and 4, we actually start to see a breakdown in the ability of the lymphatic system to drain that fluid. And that's because the tissues are full of fluid and the lymphatic system, there's a blockage along the pathway, some nodes have been removed and the vessels attached to the nodes aren't working anymore. And so we get this backup of fluid, and so there's a high pressure in the tissues and there's a high pressure in the lymphatic system because all of the available drainage is being used. And then we start to get those cellular waste products building up in the tissues. So the proteins, maybe some of the waste products that are in there. And this can become problematic if we do get any infection, so even a little cut or scratch into the affected limb, because the fluid's not moving freely, that can easily develop into quite a serious infection, even requiring hospitalization at these later stages. And the skin will become thick and fibrotic. And then eventually the limb will be that extracellular space will be infiltrated with more fatty cells and a different cellular matrix. So you'll get these kind of irreversible changes to the limb eventually. So I think that when some people come in to, the breast cancer space and they have a lot of anxiety about lymphedema, and people will often share with me that they've had a relative, and particularly if it was an older relative where, I think that in the past lymphedema was very poorly managed. So they might have had a grandma or an auntie who ended up with a really large fibrotic arm. And obviously people are absolutely terrified of them, that happening to them, which is completely understandable. So when we have the lymphedema developing in the limb, the early signs would be a feeling of tightness, heaviness, and fullness. There might be some aching, and then this kind of dynamic swelling. So it might be worse at the end of the day, improved upon waking. People might notice that the top of their t-shirt feels tight on one side. Jewelry, including watches, rings, that kind of thing might feel tied up on the affected side. Might be some issues with moving, and also as that lymphedema develops, we'll get pitting, which is where we press onto the skin and it leaves an indent. So the traditional way to look at this would be to do a measurement of the arm using a tape measure, and we'd measure at different points. So in our clinic, we do 7 centimetres between each point, and this makes it repeatable, and we can mirror that on the other side. So we'd be comparing the affected limb and the unaffected limb, and we're looking for a 10% difference between the limbs to say, yeah, that looks like lymphedema. And really, this isn't very sensitive, because if we're looking at the size and shape of the arm, that can change for lots of different reasons. So if we gain or lose weight, like fat, or if we change our composition of the body, so if there's more muscle, less fat, or the opposite, in summer, people might tend to get a bit more swelling. So it gives a good indication, but it's not very, very accurate. And it's not letting us actually look at the extracellular fluid. It's just measuring the whole of the arm and all of the whole of the tissues that are involved in the arm. So I think what's been a huge game changer for the diagnosis of lymphedema is the introduction of bioimpedance spectroscopy. So that's with the SOZO software platform, and this allows us to produce a lymphedema index score, the LDEX, and if you're able to access this technology, you just stand on the little machine, put your hands and feet on it. It takes about 30 seconds. And this puts a little electrical current throughout the body, which measures the resistance of different tissues, and it kind of maps the contents of the body pretty accurately. So this is this is like my favorite thing. I absolutely love it. I think it's so helpful for us in facilitating the diagnosis of lymphedema, and it gives a really great visual for the patient to kind of understand what's happening with their own body. So I'll show you that in a few slides. The other really, really great thing about bioimpedance spectroscopy is that it's enabled us to identify this stage 0 in lymphedema. So traditionally, we had to wait until the swelling was visible before we could start to, think about it. But at stage 0, it's a subclinical stage of lymphedema where there's probably not any swelling. So there's something changing within the tissues, but it could be months or years before that actually manifests as visible swelling. So when we're using LDEX in the clinic, this is a really great way for us to start to see a concerning trend, and then we can start to deal with that before it becomes a more problematic issue. I think we all know that kind of identifying anything early on, it makes it easier to manage, I think. So when we do the SOZOs, when we get our patients to stand on that little machine, it produces a report like this. So this is someone who's had annual surveillance over a 12-month period. So we start at the pre-operative stage where we get a baseline measure. And this is, just getting trigger happy there with my clicker. We get a pre-op baseline, which is so helpful for us because it helps us understand what's normal for that person. If we don't have a baseline measurement before the surgery, then it might take us a little while to figure out what's normal for the person, and that's still absolutely possible. But if we can get the baseline at the pre-op, it makes the whole post-op process run that much more smoothly. So this person's come in and they've had their surgery in September, then typically we'll try and catch up with people at around the 3-month mark. And we can see that this has come up away from the baseline, which indicates an increase in fluid in the arm. And I forgot to say the LDEX can only look at fluid in the arms or the legs. And so unfortunately, we can't see fluid in any other parts, but this is looking at the arm and the left arm in this case. And so we can see that the fluids come up, and then likely we've reminded that person to keep going with their exercises. They might have had some radiotherapy in here. And then the next time we're seeing them a few months later, this is coming right back down towards the normal value of the pre-op, and then they've carried on in this trajectory. So this is an ideal course for that person in the post-op period. This is what we'd like to see, and this is ideal for people recovering from breast cancer surgery. And this would be very typical for someone who's a sentinel node biopsy where the risk is lower. So when we could identify the lymphedema in that early stage, University of Kansas study showed that when we can identify the lymphedema at stage 0 or stage 1, it should be largely reversible. So definitely reversible at stage 0. for most people of us, we're at stage 1. But when we get to stage 3 and 4, we're more managing the chronic progressive nature of lymphedema rather than being able to reverse it. So this is why LDEX can be so helpful, because this is really where we want to capture those early changes so that we can help the person to, turn that around. So I'm just going to give a couple more examples, because I think that this really makes it clear the process. So this is a typical surveillance scenario where we'll see the person at the pre-op and we can see the baseline minus 4.7. So that means there's already some asymmetry between the arms. So 0.0 means everything's exactly even, but hardly anyone is that at baseline. Hardly anyone's exactly symmetrical. So we've had the baseline, and then we're checking in every few months in the post-op period. And then for whatever reason, maybe there's been some adjuvant therapies, maybe the person's thought, hey, I'm fine now, I'm going to stop doing my exercises. And the lymphatic fluid, we can see it's increasing to this subclinical level. So the yellow represents the subclinical level, and then beyond that is more like the start of lymphedema. And so they've come in to see a friendly physiotherapist. We've reminded them about their exercises and their self-massage, and we see that fluid coming right back down again to baseline. So often there's no need for any other intervention. Rather, it's just exercise and massage are the first line that we give. And from experience, we know that that can be really effective in turning around these early changes. This is another example of someone who's come up. We're doing our 3-month check, and they're showing early lymphedema. And this would have just been, so we've got just a couple of weeks between these points. So they've come in, seen the physio, and we've said, hey, come on, let's get those arms moving. Check for if there's any kind of firm scar tissue, anything like that. Reorient the person to their self-management. And we see that trajectory quickly coming back down to the baseline. This is another case study I thought was interesting. This person, we haven't seen them until 2 years after the surgery, but we can kind of see that we can get these changes at any time. And so they've been brought up and we said, hey, come on, step on the LDEX. We can see that increase in the fluid, and then we might be like kind of doing some arm measures as well, looking for other signs. And then the person might say, oh yeah, my arm has been feeling a bit funny actually. My t-shirt's been a bit tight at the top. I think this person ended up having a compression sleeve, and that's what's helped them to get down to the baseline. So those are just a few very basic examples. I could just sit here all day and give you examples of this, but this is the pattern that we want to see with early surveillance, that early diagnosis, early recognition that some changes towards lymphedema, early management, and then coming back down towards baseline. So this is all relating to upper limb lymphedema, which is really well researched now, and we have the LDEX, which is really supporting us to give this great early management. The other thing I wanted to mention was breast lymphedema. So with breast lymphedema, the diagnostic process is less clear, so we can't use LDEX. There are some ways that we can diagnose, help us diagnose breast lymphedema using lymph scanners and such, but they're not very widely used. And there's no kind of gold standard diagnostic pathways. There's a usual process for diagnosing breast lymphedema is from an objective assessment and the subjective report of the patient. So we'll be looking for redness in the breast, skin changes, including kind of a thickness in the skin, these visible pores that could be pitting. The breast might obviously increase in size because of the fluid increasing the volume of the fluid, and also the patient might report a feeling of heaviness, aching, discomfort in breast tissue. Whatever the kind of lymphedema that is diagnosed, the early management, the front line of early management for manifest lymphedema, so for stage 1 lymphedema, will be to go into a compression garment, so a sleeve or a bra, or there's all kinds of products out there, and a glove, and alongside, so that's a kind of passive way that just stops the tissue from filling. So it just helps to encourage that fluid to drain by not letting it fill the limb. And then also we will be absolutely encouraging that person to carry on with their exercises and teaching them how to do self-drainage, self-massage. So our basic management principles always include movement, activating the muscle pump. It is such an integral way to move lymph fluid in the body. So whether we're healthy or whether we're at risk of lymphedema through having a lymph node surgery, for all of us, this is such an important way to maintain health. Massage is a great way to move lymph. Also diaphragmatic breathing, activating that pump in the thorax to pull fluid back into the main system. And then elevation, which is more practical for the legs. I should just say here that the breast itself is a real disadvantage in the movement stakes because there's no intrinsic musculature of the breast. So the breast absolutely relies for all of its movement. If we didn't move, the breast would 100% never move by itself. So the upper limb movements, so any upper limb exercise where the arms are moving up above the head is going to move the breast. So if you look in the mirror, check out how the breast's moving when you move your arm, and that's a primary way that improves the circulation of the breast. And also massaging in an upward direction can encourage the flow. So when we have a larger breast particularly, it's just like a cup that can fill with fluid. And so those movements and massage and also wearing a well-supported bra are all really important for the breast health. And finally, my takeaway message is that if you can access an allied health practitioner for regular screening if you can connect with someone in the pre-op period, that is fantastic, but definitely in the first 12 months after the surgery. And it might feel like, why am I coming? Nothing's happening. But I think we really see it's a great way to keep engaged with self-management, to be reminded to exercise. As the dust settles after the cancer diagnosis, probably the mind is more able to receive new information. So we might talk about the exercise resources that are available. We might be able to make other referrals, there might be some, problems with the shoulders as a musculoskeletal issues arising. Our high-risk groups are people who've had more lymph nodes removed, so the lymph node dissections, and people who are having a lot of other therapies, so chemotherapy and radiotherapy. That's kind of the highest risk group. But there's risk involved for anyone who's having lymph nodes affected by surgery. Exercise, stretching, and massage alters the lymphatic drainage, so lymph flows faster during exercise. So exercise is a primary lymph mover, so important for our lymphatic health and the health of our body. And then if we are getting these lymphedema changes or this, if we can identify subclinical change or early lymphedema, early management with exercise, compression, and education, that's linked to significantly improved outcomes. And so really super passionate about this. If you can connect with an allied health therapist, a trained lymphedema therapist to support you in your kind of cancer recovery, I think it's so important. It's so powerful for your long-term outcomes. So I'm going to leave you with my favorite slide. My favorite quote, which I have up here in my office. So if we had a pill that conferred all the confirmed health benefits of exercise, would we not do everything humanly possible to see that everyone had access to this wonder drug? Would it not be the most prescribed pill in the history of humanity? So really? Hi.
Hi, I'm just unhiding my screen so I can say hello again. Thank you so much, Christiane. That was absolutely fascinating. Now, I've collated a few questions. I hope you don't mind. If you've got a few minutes, I can
Sure.
ask you a few
Ask
questions.
away.
So just then near the end, you were saying like it's so important for people to find an allied health professional, a lymphedema therapist. How do people find one of those trained therapists?
That's the great question, Chandrika. So if you go to the website of the Australasian Lymphology Association, the ALA, um, that has a list of accredited practitioners that I think you can put in your postcode, and it'll bring all the people up in your area. So all of
Okay.
those people have gone through rigorous training. The training to be a lymphedema practitioner is hard. So all the people in there, it's a great place to start looking.
Great. So that's the ALA website, the Australasian Lymphology Association.
Correct. That's correct. And this also has lots of other resources, education, webinars that you can download. It is fantastic.
Great. I also noticed the emphasis on exercise, which here at Breast Cancer Care WA, we are big fans of getting people involved in exercise as soon as possible, for as long as possible, as much as they can tolerate.
Love your work.
And I noticed that image of people like lifting heavy things. And I've heard around the traps, a little bit of concern. Is there any risk of any kinds of exercise provoking or aggravating lymphedema?
Yeah, so I think that these are old thought processes. So definitely there was a time where people were actually told not to exercise if they were at risk of lymphedema, because literally there was so little knowledge about it. But there's been extensive research studies to show that there's no adverse effect. If you were doing any kind of resistance exercise or weightlifting, whatever you'd like to do, I just say as a little, how do you say, a little provide, extra information to that. In the immediate post-operative period, so particularly if you've had more lymph nodes removed, so we've got our highway and the pathway for the lymph to drain is potentially altered. So while that's all settling down and the body's hopefully figuring out what to do with that, we ideally don't want to rush fluid through the system with too much vigor. So we want to moderate our exercise engagement, definitely for the first 6 to 12 weeks after surgery, and not increase the cardiac load hugely during that time while everything settles down after the surgery. When we start to re-engage with exercise, the best advice with all exercise, for healthy people and people at risk of lymphedema, is to graduate. So it's particularly starting a new program. So it's great that we have lots of experts to help us out there in the community. Is to start with basic, I'd say, range of motion, and then if you're going to load up, doing it bit by bit and monitoring your response. So if you have a lot of increased pain or discomfort after an exercise session, particularly in your affected arm, then that's definitely something to be, reach out to an allied health person to support you with that. I'd say if you're not sure about how, or an exercise physiologist, or to help you graduate back into exercise. But 100%, the benefit of exercise far outweighs any associated risk.
Yes. Okay. So start slow and steady. And probably if you are thinking that you're vulnerable at risk, you might want to see an exercise physiologist or a physiotherapist
100%. I think
so
to
that you
have
get some
someone,
tailored support.
yeah, to have someone I think they're overseeing, and particularly sometimes people, these are secretly my favorite people who come to exercise through a challenge. So they're having a challenge, they're having a health challenge, and through that process, they discover love of exercise. It's close to my own heart. And they embrace that journey. And I think it is so powerful and so helpful to have a skillful professional to help step you through that process. And particularly, the average age of diagnosis for breast cancer is a little bit in a kind of a slightly older age group. And so definitely if we're starting exercise in that period of life, I think it is really great to get a bit of help and guidance.
Yeah. And maybe put yourself in a tailored small group setting like our
100%.
Living Well programs, for
That's
example.
exactly right.
So I had a couple of other questions come through. Why doesn't everyone get lymphedema then? A lot of people have lymph
Another great
nodes
question.
removed. A lot of people have treatment to that area with breast cancer. Why doesn't everyone get it?
That's a great question. So, I wouldn't know exactly precisely the answer to that, but you're exactly correct that 100% not everyone gets lymphedema. So with sentinel node biopsy, we'd expect to have, a low rate of people to progress into lymphedema, but still some people will get, even with one node removed. So that might be to do with, scar tissue or problems with movement of the limb, which are just not letting the lymph move as well as it could. With the more extensive surgeries, so your lymph node dissections, and people who are having more adjuvant therapies, they're at a higher risk of having lymphedema because more lymph vessels, more of the lymphatic system is impacted by the surgery. So that can absolutely obstruct the lymphatic pathway for some people. So if our arm is draining predominantly to that area affected by the surgery, these are the people who are going to have the most problems. But our lymphatic system is like all of nature, is super smart. There are what we call anastomoses along the system, where the lymphatic fluid goes directly into the venous system before it goes through the whole pathway. And there's kind of dormant pathways which are not very operational in the healthy system, but there's this kind of backup pathways that could start to work more when the need arises. And the way our body drains is really variable. It's not like we all have exactly the same lymphatic system. It's similar, but where the exact pathway that our nodes and vessels lie in can be a bit variable. So I think for some people, they just are more advantaged by how the arm is naturally draining. And then for some people, they'll have more struggle. And that can be for like higher risk, I'd say, kind of older people, more extensive surgeries. Um, and then if people are already not moving very well before the surgery, that can be something we definitely have our eye on. But we'd still, as I say to my patients, particularly if they're concerned about lymphedema, your chance of not getting it is way higher than your chance of getting it for all people. You've got a way higher chance that you'll be fine in the long run. But I'd say that is that chance to not get it is absolutely bolstered up by staying engaged with allied health for at least the 12 months after the surgery. You'll definitely get the best chance of a good outcome.
Yes, which leads me to my next question then. If early identification of that stage 0 is so important and it is potentially reversible, why isn't everybody screened or assessed for lymphedema before treatment starts?
Another great question. So I think the main barrier to that kind of really extensive lymphatic surveillance and early management is that lymphedema management isn't supported by government funding. So there's no specific, there's a little bit of funding for it, but definitely not across the board. So that's probably one of the problems with lymphedema, is that once you develop lymphedema, it's really up to the individual to access therapists, to renew garments. There's very little support for the individual. So it's a huge burden, not only on the health, but also financially. So I guess that's why we don't have a pathway that everybody follows. And that's why I'm so grateful to our service for supporting this. Has been absolutely supported by the research that this preoperative assessment followed by early surveillance gets the best outcomes. But unfortunately, for some people, that will be very much the burden of that will be on the individual to seek out that support. It wouldn't be part of standard management. And also, say, if you're living in a regional area, those services are extremely limited.
Yes, okay. So we've got a gap there. We've got problems to solve, but you've given people, I think, a lot of great ideas on self-management. I've got another question about self-management. Does, fluid intake and diet have any impact on lymphedema?
So, yeah, 100%. So keep staying well hydrated will kind of keep, I think, at like a good level. So when we actually do the LDEX, in the back end of it, you can see the body composition. And one of the things it has is something called a HYDEX, so we can see how hydrated the person is. So and sometimes if we're having a struggle to get a reading, we might say, if you had enough water to drink today. So it's a bit like, I have all these water analogies, but if we're a bit dehydrated, it's a bit like a sluggish stream in the summer. We're going to be having a more sluggish lymphatic flow, and then there'll be more cells versus the water. Also, definitely maintaining a healthy diet, and a big issue with lymphedema management, and indeed in breast cancer in general, is obesity. So as soon as we have more obesity in the body, those little lymphatic vessels, which are really weak and low pressure, they're struggling against a higher body mass, and they're going to be more restricted naturally. But by having that kind of more fat cells in the body. So I'd say definitely hydration and diet are, so important in that recovery space, or indeed for all
Mm.
of us.
Yeah, for all of us. Okay. Look, I think we've gone for about an hour, and that's probably enough. But if people have more questions, they can certainly get in touch with Breast Cancer Care WA. And I'll just remind people that we have breast care nurses, we have counsellors, we have support groups. We also have our Living Well program, which includes exercise medicine, which is led by exercise physiologists. We have a yoga therapy program, both online and in person. And we've got discussion groups, we've got a mindful recovery program, we've got all kinds of drop-in workshops and activities to help you stay educated, stay informed, stay inspired to do all of the good things you can do to support yourself and your well-being. And we're so grateful, Christiane, for your time and expertise in sharing your knowledge with all of us today.
And thank you, Chandrika. It's a great opportunity. I'm really privileged to have been asked.
Thank you. There we go.